Greetings and welcome to the Research Update webcast. At this time, all participants are in a listen-only mode. If you have not already done so, please close all of the programs on your computer. You may submit a question via the web at any time by using the Ask a Question feature on the left side of your screen. It is now my pleasure to introduce Samantha Deegan. Thank you. Please begin.
Thank you for joining us for today's webinar. The Bassler Center for BRCA at Penn Medicine's Abramson Cancer Center is the global leader for the research, treatment, and prevention of BRCA-related cancers. Devoted to advancing care for people affected by BRCA gene mutations, the Bassler Center's unique model provides funding for collaborative research, education, and outreach programs around the world. Dr. Edward and Mary Prostek have generously established this webinar as part of the Elizabeth Prostek Memorial Outreach Program in memory of their daughter. The following video is a tribute to Elizabeth, her incredible life, and her dream of creating communities that increase awareness about BRCA and metastatic cancers. The Bassler Center is proud to be a part of this mission by providing life-saving information and hope to individuals and families worldwide. Please begin the video.
Tomorrow, bet your bottom dollar that tomorrow there'll be sun.
Lizzie Prostek was an amazing young woman who believed in the promise of tomorrow. And though her tomorrows were cut short, we can celebrate and sustain her optimism. Lizzie lived large. She loved the stage and brought it to life with her voice and her energy as a talented child and as she grew into a woman. Her world was full of loving friends and family, and success in class, in sports, with girls and with boys. Sophomore year of college, Lizzie met Michael Lundblad, a liberal and an English major. He got a preview of her leanings when he saw her quizzing a friend about senators. But she learned to love camping. He learned about couture. And political opposites, Michael and Lizzie spent 10 years together, marrying their minds and their passions. Michael loved her boldness and her softness, her interest in so many different types of people, and ability to remember the small details of their lives. The time she made to talk with her grandmother, her pearls, her red shoes that said she was not afraid to be noticed. She was not afraid. Lizzie's intellect and drive were rewarded with exciting opportunities. She blazed through the University of Pennsylvania and into the halls of government, determined to win in every venue and for every cause that was important to her. Her work for senators and on committees quickly made her a Washington insider. She rose to Chief Privacy Officer and Senior Advisor to the Secretary of Commerce before being lured away to the private sector. Not yet a lawyer, she was named Managing Director at Sun & Shine, Nath & Rosenthal in Washington, D.C., and was completing her law degree at night at George Washington University when she died. When Lizzie was awarded a posthumous degree at the law school graduation, the entire audience stood in tribute to her spirit. Lizzie was 31 when she was diagnosed with stage 4 metastatic breast cancer, and her daughter Harper was 4 months old. Michael did research. Lizzie didn't want to know the odds, expecting to beat them. But the cruel reality was that although breast cancer is generally curable, metastatic breast cancer is not. And they found little support to help them deal with the psychological and emotional realities they had to face. In her last months, Lizzie and her family began to envision an online support network that would show patients with metastatic disease that regardless of how long they have to live, they have the ability to control how they live. This was Lizzie's final cause, and one which will be honored. Lizzie wanted to see her daughter's first birthday. She didn't make it, but she lives on in the people who loved her, and through grants such as this one being made in her name. And in truth, none of us knows how long we'll live, so we all should listen to Lizzie and make the most of every tomorrow. Live large, live strong, and wear red shoes.
Tomorrow, you're
Today's program will look at advances made in BRCA-related research over the past year and will highlight important work that will be ongoing in 2019. As always, this presentation will be archived and available for viewing later this week at basser.org/webinar. I'd like to introduce our speaker. Dr. Susan Domchek is a board-certified medical oncologist, Basser Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania, Executive Director of the Basser Center for BRCA, and Director of the Marianne and Robert MacDonald Cancer Risk Evaluation Center at the Abramson Cancer Center. Her work focuses on the genetic evaluation and medical management of individuals with inherited risk factors for cancer. Dr. Domchek is particularly interested in developing new cancer therapies, such as PARP inhibitors, for breast cancer patients due to genetic risk factors. And Dr. Domchek, the floor is yours.
Thank you so much, and I'd like to thank the Prostic family for the support of this important series. I'm just looking at my slides. There we go. All right, so just to get started, just as a reminder that germline genetic susceptibility and germline genetic testing really does serve as a paradigm for individualized care. You might hear these terms: personalized medicine, precision medicine, and there's no greater example of that than inherited susceptibility to cancer. These inherited susceptibility to cancer can target whether people are at risk for cancer, what we can do to decrease that risk, and also, most importantly, whether or not we can treat it differently. And BRCA1 and 2 has really served as the prototype for this, although we are increasingly exploring genetic factors of breast and ovarian cancer beyond BRCA1 and BRCA2. So at the Basser Center, we've been very focused on BRCA. We serve as a clinical center of excellence, providing genetic testing, risk assessment, risk management, cancer treatment. But more importantly, we'd like to continue pioneering research to improve outcomes, to provide women and men with better choices to manage their inherited susceptibility to cancer. In terms of research, we have a number of different areas that we really would like to make progress on. These span basic science, how these genes work, and how we might be able to target at the earliest level, how they how mutations in these genes lead to the development of cancer, so we can prevent those cancers from developing, all the way into how to get more individuals tested so they have this knowledge. And I don't need you to read this slide in detail because I'm going to try to highlight areas of research in each one of these fields. Of note, we do have an annual scientific symposium this year. It's May 7th and 8th. This is very well attended. In fact, we are always thinking about larger venues. We present an annual Basser Global Prize every year with a keynote speech. The registration is open and is there. And importantly, we also have a Breakthrough and Discoveries panel, which is focused more in lay language, and that's open to the public, and that registration will be opening soon, and this is all on the Basser website. Our global prize is given out yearly to a visionary scientist who has advanced BRCA1 and 2 related research. This year's awardee is Maria Jason from Memorial Sloan Kettering Cancer Center, and as you can see here, we've awarded this incredible award to individuals from London to the University of Washington and also Stephen Nayrod in Toronto, and you can see the list here. We have a number of different outreach events. In 2018, we had 9 different panel discussions everywhere from New York, California, and Pennsylvania in combination and collaboration with the Basser Young Leadership Council. These are really interesting and fun events for me. We always pair this with an individual who has a BRCA1 or 2 mutation to give that incredibly important perspective, and we really try to answer a lot of questions at these times. We've been working with Sharsheret and Force and have ongoing collaborations with them as well. And we have specific plans in 2019 for outreach into the Latinx and African American communities. We really feel this is quite important, as there is a testing in underrepresented minority communities is underutilized, and we really want to make sure to fix that problem. We feel it's really important to help guide clinical management decisions, and therefore we have published a lot of work on this, on how to think about mastectomy We work with the Global Challenge, the BRCA Global Challenge, on a website called BRCA Exchange, which has a collection of all BRCA1 and 2 related variants that are known from large databases. We have been very involved in thinking about how to do genetic testing, be that population-based or the various different options that are out there for individuals, and we'll be talking about that more as well. We really do want to decrease barriers to genetic testing, and at the same time, we feel this information is extraordinarily important and needs to be thought about in the context of someone's overall medical care. So we have many ongoing studies trying to figure out how to do genetic testing differently. And there are many different studies that are there. One approach is not necessarily the right thing for everyone. I think there needs to be multiple different approaches so that we can decrease these barriers and get more people testing. We know that too few people to get testing. Interestingly, we're particularly bad at testing cancer survivors. And a particular example is that a study that was done that we weren't involved in showed that ovarian cancer patients who have survived their ovarian cancer, only about 10% of them have gotten testing for BRCA1 and 2, even though all of them are eligible to do so. And this is really important because genetic testing may just not have been available for them at the time of their diagnosis, and now it's not recognized that they need to go back and do this. It's also known that family members don't always get tested even when a mutation is known, so we want to decrease those barriers as well. And there's all sorts of interesting discussions about what we should test for and who should we test. And if we do things like population screening, why stop at cancer? Why not also test for all the cardiovascular diseases that we know about? So this is a really interesting area of debate and research, and trying to figure out how to implement these things is really important. So how do we implement them? My colleague Angela Bradbury, who's been funded by Vassar, has been doing a lot of research on telegenetics models, doing remote video conferencing. And one of the projects that she did was to offer individuals remote testing by teleconference or video compared to usual care. Now, all of these individuals were referred to genetics programs. But interestingly, if you offer people telegenetics, 77% actually did do genetic counseling, compared to 6% of those who were basically giving contact information for how to access a genetics program. These were all hospitals that did not have a genetic counselor on site. And for this reason, we've really been interested in expanding telegenetic services. So Dr. Bradbury has a very large telegenetics program that she's developed, and we have a few different initiatives here. One is a patient access program where individual patients can enter this program, and currently this is the telegenetics part is at no cost to the patient. We're actually trying an interesting model where philanthropic donations, even from the patients who've gone through the testing, may pay it forward. So that's an interesting approach. And the way that this is done is that people come into a website, they put in their information, they kind of bring their doctor in with them so that we can, so that the team of counselors can convey the information back to the doctor. In addition, Dr. Bradbury has a study open soon that's comparing telegenetics models and web-based models to the standard genetic counseling models. So this is looking at digital health communication compared to the traditional models. Genetic counselors are incredibly valuable, but the question is how to use them to their best capacity. And sometimes patients will need less pre-test education and more post-test education. We also have an ongoing study that we are one of 4 sites and have enrolled 2,600 of 4,000 patients looking at a digital health platform to test Ashkenazi Jewish individuals for BRCA1 and 2 founder mutations. And this is meant for people who don't necessarily have any kind of family history. This is for anybody of Ashkenazi Jewish descent. We've also been interested in doing genetic testing at the time of a patient's visit without requiring an additional appointment. This is a collaboration with Memorial Sloan Kettering. And we've been offering all patients with pancreatic cancer or metastatic prostate cancer the chance to enroll in this study. They do a brief educational video. They have a sample collected, and then they are called with a genetic counselor with that result. And as you can see, we've enrolled more than 400 patients on this study, and we have definitely, there's a typo on this slide, and my apologies, but we've detected about 8% of these individuals who have mutations. This is a massive increase in the number of people tested with these diseases compared to the year before. So if we go to them, many more individuals get tested. So these are just examples of how we're trying to, in a systematic way, with research aims, expand genetic testing outward. Next, I want to talk about clinical trials. So I think many of you have heard about PARP inhibitors. And in PARP inhibitors, the concept is that on the left you have a cell that has a BRCA1 or 2 mutation, and it is unable to repair double-stranded DNA breaks. If you give a PARP inhibitor, the cell on the left that already has compromise of function can't repair DNA by 2 different mechanisms, and the cell dies. But on the right, a normal cell has an ability to repair that DNA, and in the setting of the PARP inhibitor is able to tolerate that insult and survives. This, of course, is the current model of this is somewhat more complicated. It involves things like PARP trapping, but the general idea is that you have 2 hits when you give a PARP inhibitor, and that's why these drugs are particularly effective for BRCA1 and 2 mutated cancers. So there's been a number of drugs approved. The first ones that I have the highlights on here are PARP inhibitors that have been approved for ovarian cancer, including most recently for first-line maintenance of BRCA-related ovarian cancer. So what does that mean? If you're diagnosed with ovarian cancer, get your upfront chemotherapy. There are now good data that taking a PARP inhibitor, and the specific approval is for the drug called olaparib, significantly reduces the chance that that individual will relapse with their cancer. And so this has been a progression over time. The first trial, the first FDA approval was in 2014 for BRCA1 and 2 related ovarian cancer that had been heavily pretreated, and now we're treating right in the first line. For breast cancer, there have been 2 approvals, one for olaparib up top, and the second for talazoparib, which is just in October of last year. And so now there are 2 approvals for metastatic BRCA1 and 2 related breast cancer. And to show you an example of this, this is the study that we were involved in at Penn, where women and men with metastatic breast cancer with a BRCA1 or 2 mutation were randomly assigned to olaparib, which are pills, twice a day, compared to chemotherapy. And what this demonstrated that the individuals who took olaparib, their tumors shrank 60% of the time compared to 30% of the time in the chemotherapy arm. Now, what we have seen is that in terms of, and their tumors took longer to grow, in terms of overall survival, the women and men who had the PARP inhibitor as their first therapy in the metastatic disease lived longer with the PARP inhibitor compared to chemotherapy. That was not true if they received the drug later. And again, this is chemotherapy compared to a PARP inhibitor. These curves are better, but they're not good enough. And so our next strategy is obviously to try to figure out how to make those responses better and last longer. And one of the approaches is to try to turn the tumors into immunologically sensitive tumors. Here you see a slide where on the right, hot tumors, which are responsive to immune therapies, these are things like melanoma and some lung cancers. Whereas on the left, breast cancers and ovarian cancer are relatively cold tumors. And BRCA1 and 2 related cancers really do mostly fall in that group. So there's been a lot of interest in how to make these tumors respond better to to immunologic therapy, and that may be in part combining with a PARP inhibitor. So we've done a study looking at one of the PARP inhibitors called olaparib with a immune therapy called durvalumab. And what we can see is that there are a number of responses, although these are relatively small studies in both breast cancer and in ovarian cancer. And studies are ongoing to see whether or not adding the immune checkpoint inhibitor will be helpful in terms of making those PARP inhibitor responses better and longer. So time will tell, but it's in a very interesting area. Now, getting to the science behind it, the basic science behind it, my colleague Kate Nathanson and Kara Maxwell have been looking at this issue, and the traditional idea behind BRCA1 and 2 related tumors is that you're born with one bad copy, you lose the second copy, and that is how cancer develops. And this is really kind of this two-hit hypothesis. And even in the early studies, it was shown that there are some tumors that did not lose that second copy. And this has always been an area of interest and speculation. The data that were done showing PARP inhibitors were effective in BRCA1 and 2 related cancers, you really have to have loss of the function of BRCA1 or BRCA2, meaning loss of both copies for PARP inhibitors to work. So one of the interesting things is that not all tumors respond to PARP inhibitors, and there's a number of different suggestions of what those mechanisms of resistance might be. There can be secondary resistance mechanisms, acquired resistance, and by that we mean that the resistance mechanism occurs after the PARP inhibitor is given. And these are things like reversion mutations or things called fusion proteins and all sorts of basic biologic principles that can result in a resistance. But there also may be primary resistance mechanisms, meaning before you ever even give a drug, maybe there's something about the genomics of the tumor that make it less likely to respond to a PARP inhibitor. And some of these are, the questions about whether specific mutations might be less likely to be responsive to a PARP inhibitor. There are no actual clinical data regarding that. There's a question about whether these things called reversion mutations, second mutations in the cancer, could be there from the baseline. And the third thing is maybe sometimes the second copy is not lost. And so again, I'm going to try to highlight who does this work all along, and this is Adam Crea, Carol Maxwell, Kate Nathanson, and Bob Bonderheide, who have done the work that I'm going to show you next. But Kara and Kate looked at a number of different tumors, both from a large public database called the TCGA and PEN tumors, and looked to see how often that second copy was lost. And that when the second copy is lost, we call that LOH, loss of heterozygosity. And the important thing here, because I don't expect you to remember or know all this slide, but the most important thing is that particularly in BRCA2-related breast cancer, there were a number of tumors that did not lose the second copy. And that's just interesting because it may be that can impact therapy and outcome. So for instance, in this study, in ovarian cancer, if there was loss of the second copy, tumors did better. And this may be because in ovarian cancer, patients pretty much always get platinum, and this may make the tumors more sensitive to platinum. Where in breast cancer, when there wasn't loss of the second copy, these tumors may do better. So this is really early data, and this is also in primary tumors. So this is not in metastatic tumors. This is not in tumors that have come back outside the site of origin. And there is a lot more work to be done, but still it just gives us a hint that things are more complicated than they seem, which is usually the case, by the way. So we've also looked at what the immune responses are like in this. And again, this is a complicated slide. This is how we present our data. But basically what it shows is that in the tumors that have lost the second copy, there actually isn't as good an immune response as when there's not. And that initially seemed counterintuitive, but there's other work that is very consistent with this. And this basically comes into a model that shows that tumors that may be most sensitive to immune therapies may be least sensitive to PARP inhibitors and vice versa. And this may mean that combining the two together is a great idea because the PARP inhibitor can treat these and the immune therapy can treat these. Again, lots more work needs to be done, but an interesting concept about why things may be in combination. There's other agents that is being studied, and we published a study last year looking at an agent called lurbinectedin for BRCA1 and 2 related cancers. This is not FDA approved, but work is ongoing with that. And we also know that these drugs can be effective in more than just breast and ovarian cancer. So even in the earliest studies, it was demonstrated that PARP inhibitors had activity in BRCA1 and 2 related pancreatic cancer and prostate cancer. This is an example of a paper we just published last year. It was a relatively small study, and the reason it's so small is because we needed to see 3 responses in the first 15 patients to keep going, and the 3 responses we saw were in the last 3 patients of the 19 we treated. So that was unfortunate. We had a total of 4 responses, but this man here is actually still on drug more than 4 years later with BRCA2-related metastatic pancreatic cancer on rucaparib. So this is an area of great interest to us, and my colleague Kim Rees-Binder is leading a clinical trial looking at BRCA1 and 2 related BRCA1, BRCA2, and PALB2 mutated-associated pancreatic cancer. And after individuals have a chemotherapy, including a platinum agent, they are transitioned over rucaparib for maintenance, much like in the ovarian cancer setting. There is a randomized trial called POLO, which randomizes pancreatic cancer patients to rucaparib versus a sugar pill. We preferred this trial design as all of our patients obtain rucaparib, and we have a lot of clinical trial correlates ongoing. There's also a lot of interest in BRCA2-related prostate cancer. We have had a long-standing involvement in a study called IMPACT, studying prostate cancer screening, led by Roz Eels in the UK. Kara Maxwell at Penn is looking very closely at prostate cancer tumors and the germline of patients out of a very large Penn Medicine biobank that we have. We are expanding this also to our Veterans Affairs hospital, our VA hospital, and doing specific analyses in the African American community. And as mentioned before, we're doing increasing testing via our point-of-care trials and trying to ensure access to clinical trials in this space. Now, related to BRCA1 and 2 related ovarian cancer, there's a large group doing research in this area. Ronnie Drapkin is our director of gynecological research at Vassar and is the director of the Ovarian Cancer Research Center. And Fiona Simpkins is one of our stellar junior colleagues. And they have a very large program called the Translational Center of Excellence, looking at many different components, including live tumor bank organoids, patient-derived xenograft models, which are basically mouse avatar models, and then and also a rapid autopsy program, which allows for us to look at what the tumors look like at the time of a patient's death, which is an incredibly valuable and generous resource, but it really gives us an incredible amount of information. Some of the studies that are specifically being done here, we are a site in the WISP trial. The WISP is called Women Choosing Surgical Prevention, and is looking at whether or not taking out the fallopian tube alone and delaying removing the ovaries in BRCA1 and 2 mutation carriers can be a good idea. I want to be clear that the standard of care remains to remove the ovaries and the fallopian tubes by 35 to 40 for BRCA1 and 40 to 45 for BRCA2, but we are hopeful that we can be more precise in those recommendations and spare people early menopause. Another approach to this is to do better ovarian cancer screening. I think everyone on this call is well aware that one of the major challenges of ovarian cancer is the absence of effective screening. So one concept here is, because it's thought, and Dr. Drapkin was very involved and led this work, that many ovarian cancers arise in the fallopian tube, that maybe you need kind of the pap smear of the fallopian tube. This is not as easy as it might sound, but because people are clever, there has been this microcatheter technology that's being developed where they can snake a little microcatheter into the fallopian tube and collect cells there. So this is under study. This is obviously, not something that is clinical, but there is a prospective trial that is underway to test this technology in high-risk women. If we can improve detection and we feel better about the ability for us to detect ovarian cancer, women will have much better options. And then again, we can use the PDX models and these little mouse avatars. So what are PDX models? Well, our surgeon, Fiona Simpkins, when she does surgery and with the consent of patients, takes samples and actually takes them back to the lab, does surgery on mice, and places these cells right on the ovary of the mouse. And that allows us to test drug combinations and to look to see which may be better. So this is a curve which can show you that PARP inhibitors significantly reduce the tumor growth, but if you combine PARP inhibitors with something called an ATR inhibitor, this looks much better. And many of these figures are showing similar things. And this has led to a clinical trial, again, led by Dr. Simpkins. This is both at Penn and at Hopkins. And it's looking at individuals who have recurrent ovarian cancer and treating them with both olaparib and an ATR inhibitor to see how things go here. And again, this is both for platinum-sensitive and platinum-resistant patients. So this is a very interesting and important study. Another angle on this is to use the immune system in a different way. So I talked earlier about using drugs called checkpoint inhibitors, which basically just press on the gas in the immune system. But if you have to press on the gas, you need gas in the tank. And so checkpoint inhibitors work when there's already existing T cells around that can help with the immunology. This is a different approach here, which is to take a T cell and make it into what you wanted. So some of you may have heard of things called CAR T cells, and these were developed at Penn and initially approved to treat childhood leukemias. They've also been approved for adult lymphomas. And so these are engineered T cells, and they're basically made into super T cells that can attack cancer, and you can program it to attack whatever you want. So in this particular study, there's been a ton of preclinical work to look at CAR T cells, which is against a folate receptor alpha. And folate receptor alpha is expressed in up to 90% of ovarian cancer cases, and specifically is expressed in BRCA1 and 2 related cancers. So this trial has just started, and it is being, the clinical principal investigator is Payal Shah, one of the medical oncologists who works with us at Vassar, and so we're really interested to see what this may entail. Of course, we'd like to do prevention. I think that we are well aware that the concept of better treatment is great and all, but it would be far, far better to never be dealing with this in the first place. And for that reason, there's been a number of approaches that have that are of great interest. Because of our interest and expertise in Penn, we are very interested in using the immune system to try to prevent cancers. We have completed a trial looking at a vaccine involving TERT DNA, which is against telomerase, in combination with cytokines and then a little bit of an electrical jolt. And this study was done in individuals who had had cancer but were at risk for their cancer coming back. The trial was completed. There were nearly 100 patients. It was safe. There was no excess toxicity, and importantly, there were very good immune responses. So we are now we have a draft protocol, and we are working with the company and to get this rolled out. But we are hoping that in the near future we will be treating BRCA1 and 2 mutation carriers who have not had cancer with this vaccine. The trial will initially be quite small because we need to small as we need to prove that the vaccine is safe, particularly in individuals who have not had cancer before, and we'll also look to see whether it generates an appropriate immune response. But we're very excited about this type of work. Sort of more broadly in prevention, in terms of the overall landscape, again, there are these immunologic approaches. There's also an approach using things called RAG ligand inhibitors, a drug called denosumab, called Prolia when we give it for osteoporosis, and Xgeva when we give it to individuals with cancer. There's been work done by colleagues of ours in Australia and in Austria showing that in mice this may help prevent BRCA1 related, and it's BRCA1 specifically related breast cancer. There is a trial that has begun in Austria, and the hope is that it will also be opening in the United States soon, so we'll keep you in mind for that. There are hormonal approaches. In fact, somebody has already asked a question about Duvet. A colleague of mine, Judy Garber at Dana-Farber Cancer Institute, is looking at Duvet in BRCA2-related cancers. Duvet is a combination of hormones and also something called a SERD, which potentially could have, but we don't know, has preventative effects. The question is always whether or not PARP inhibitors, the drugs that I had mentioned earlier, could be used for prevention. We're not ready for that yet, but there's a lot of interest in that space. You've heard me talk about removal of the fallopian tube as a potential way to prevent ovarian cancer, and we're very interested in whether or not we can better stratify individuals for risk. And what do I mean by that? I mean that if you know that you're at higher risk of developing cancer at an earlier age versus a lower age, or if we know that someone's ovarian cancer risk really doesn't start till 50, we could better target our interventions to specific ages. So that's another area of great interest. Now, we have a lot of basic science efforts, and usually the basic scientists get a lot of my time and attention. Today, I'm spending less time on them. I always like to give a lot of time for questions because usually we have a ton. But I wanted to just give you a sense of some of the things that we are working on in terms of basic science. Basic science can sometimes be the harder thing to explain, but in the end of the day, we need to know, for instance, whether having one bad copy of BRCA1 or 2 in itself impacts the way cells function. And you would think that we would have figured that out by now, but we really haven't. We also don't really know why it is that people with BRCA1 and 2 mutations, why the highest cancer risks are in breast and ovarian cancer. Why aren't there other cancers that are at such high risk? We know that there are other associated cancer risks, but breast and ovarian cancer dominate. So why is there that tissue tropism? If we can start to understand these basic factors, then you can have a potential for targeting interventions for prevention. We also do want to understand more about this interaction with the immune system because it's extremely important. And of course, we really want to know why tumors may be more or less responsive to therapy. So Roger Greenberg is our Director of Basic Science. Ben Black is very interested in PARP resistance by PARP mutations because PARP is something that you have in your body. Lynn Zhang has done a lot of interesting work in ovarian cancer, Kara Maxwell and Kate Nathanson, and many others that I can't quite fit on this particular slide. So the PARP inhibitor issue is important, and basically it's this issue of how these double-stranded breaks occur in the first place and how they're repaired in the presence or absence of PARP inhibitor is quite important. So there's a number of different screens that can be done, including using CRISPR screens, to also find alternative targets that can resensitize to cells that have acquired resistance. PARP is one strategy, but it may be that inhibitors to lots of other agents may similarly cause significant sensitivity, and again, figuring out this combination with the immune system. I also want to point out that at the Bassler Center there are a lot of people involved in this work. There are many clinicians, physicians who are seeing patients and nurses, research coordinators, lab technicians, all working collaboratively to advance the field. We also do have many collaborations outside of the University of Pennsylvania to help with that as well. So at this point, I always leave a lot of time for questions, and I already have a lot of questions. So I'm going to start with the first one. The first question was whether to use olaparib for individuals with breast cancer to prevent cancer recurrence. So there is a large study that's ongoing that we are very involved with called the Olympia study. In this study, individuals with BRCA1 and 2 mutations who have breast cancer get all of their breast cancer treatment and then are randomly assigned to receive olaparib or a sugar pill. The reason for that randomization is that because it is really important for us to know whether the olaparib further reduces the cancer risk of cancer coming back outside the breast. We know that olaparib and these other PARP inhibitors do have toxicity. They can cause nausea, they can cause fatigue, they can cause low blood counts. And so this trial is an incredibly important study to answer the question of whether or not we should be doing that. Whether or not the study is designed that individuals with BRCA1 and 2 mutations can come on the study, whether their tumors are triple negative or estrogen receptor positive, but the eligibility criteria are a little different for each, as the FDA wanted us to specifically enroll individuals who are at high risk for developing recurrence. And that's because we really do need to get a better sense of the toxicity data. PARP inhibitors, because they do damage DNA, there is the possibility that they could increase cancer risk and of different types, and specifically the concern is whether or not there can be an effect on cancers of the bone marrow like leukemia. So that's why we don't give them off study unless they're FDA approved and have been shown to be effective. So I hope that answers that particular question. Another question is about pancreatic cancer. This is a great and important question. BRCA2 mutations are associated with an increased risk of pancreatic cancer. That risk of pancreatic cancer is approximately 5 to 7%. And as anyone who's had a relative with pancreatic cancer knows, this is a very, very difficult cancer. It tends to sort of come out of nowhere, and people get sick quickly, and oftentimes the disease is very advanced at the time that it's detected. So one of the questions is, how can we screen for pancreatic cancer? So at Penn, we have ongoing studies looking at pancreatic cancer screening. In our particular studies, including one that is a multi-center trial called CAPS-5, endoscopic ultrasound is the primary modality, and that is when a tube is placed down the esophagus into the stomach, and you look from the inside out with an ultrasound. An endoscopic ultrasound is done yearly in that study. Other studies have used abdominal MRI. Abdominal MRI is difficult to get covered sort of off of a clinical trial and is expensive. And there's a lot of work being done in whether or not you can use blood tests to detect pancreatic cancer. And so many different assays have been developed, and now the work is underway to determine whether they are actually helpful in sort of real time. And so keep up with that. Continue to ask about that, because this is an area of great research. Another question is whether or not another question has come up about having ovaries removed and whether or not you can safely take hormone replacement therapy. So there are no randomized trials related to this, meaning, the gold standard in medicine is that you take half the group and you give them one thing, half the group give them another thing, and you look to see what's going to occur. This is that trial has not been done, and honestly, it is extremely unlikely that trial will ever be done, because individuals take hormone replacement therapy for different reasons. If people have their ovaries removed and have terrible hot flashes, they may be more likely to take it, and if they have no symptoms at all, they might not. So there's a lot of what we call confounding by indication, and and that gets tricky. But here's my sort of general philosophy about this, which is just a more pragmatic approach, which is if you have your ovaries out when you're 35, you were already making estrogen, and no one really cared about that estrogen. We just cared about your ovaries turning into cancer, and that's why we took them out. We didn't really take them out just to decrease your hormones. And in general, we give less hormonal therapy back than before we took the ovaries out. So this is an important conversation to have with your doctors. But if an individual has not had breast cancer, I do not feel that having breast tissue remaining is a contraindication. It just needs to be a discussion between you and your doctor about that. Now, a specific question was asked here about taking hormone replacement therapy after 50. And that actually gets trickier because in the general population, we now have a lot of conversations about stopping hormone replacement therapy once people kind of reach the natural age of menopause and how much that may be helpful or not. So again, very individualized decision, but important to have a conversation. And Duave, again, is a kind of a newer drug, and we still don't know much about it for prevention. It's pretty expensive, so it's not necessarily covered by insurance. So that's another area. So I've been asked about individualized risk and what that means. So I get a lot of questions in the clinic about if someone, excuse me, about diet and exercise and how that might impact risk. And I definitely feel that overall being healthy is helpful particularly to BRCA1 and 2 carriers, because if you're going to have your ovaries out at a young age, you want to have generally good health in terms of your heart and in terms of your bones and things like that. The data that it is particularly helpful in terms of decreasing risk are not quite there. In the general population that doesn't have BRCA1 and 2 mutations, we know that maintaining a healthy weight, regular exercise, and minimizing alcohol is definitely associated with a lower risk of breast cancer, although plenty of women who do all of those things in the right direction still get cancer. But think about it this way: in individuals that have a mutation in BRCA1 or 2, their risk is so high that doing these things, even if there's a modest effect, it doesn't really show up much. So again, you're doing them because it's good to be healthy for your heart and your bones and all of these other things, and it may have a risk, an association with breast cancer risk reduction, but it's going to be modest. Other things that are there, though, is that we do have some evidence that depending on where in the gene your mutation is, you may have a slightly higher or slightly lower risk of breast and ovarian cancer. So the first question you're asking yourself is, then why isn't anyone talking to me about that, and what does it mean for my specific mutation? And the reason we don't really talk about it clinically is that effect, too, is quite modest, and in itself is extremely unlikely to help us make decisions about care. You probably all remember that we give you ranges of risk. We never give sort of an exact number with a decimal point, and that's because our numbers, have some imprecision, but it's also because in different families, it looks very different. Some families get tons of breast cancer, some tons of ovarian cancer, some early, some late. Some individuals never get anything. And that variability, again, may reflect environmental factors. There's these specific mutations, so mutation-specific risk, the mutation in your gene itself. And then there's other genetic risks that may come along with your BRCA1 and 2 mutation. So the small changes in things called single nucleotide polymorphisms may affect the risk. But we do not have a unified model as yet to put all this information together in a validated way to give people more precise information. I can assure you that lots of people are working on it. It is hard. We are involved in an extremely large consortium called SIMBA, in which there are more than 45,000 mutation carriers throughout the world. We contribute DNA, as do many other centers, to answer these extremely important questions. All right, let me see. There's lots of questions here. Okay. The talazoparib. Talazoparib is one of the PARP inhibitors, and I may actually go back just to remind everybody, because there's lots of different PARP inhibitors, and it can actually get a little bit confusing. But I was going to give you sort of the secret, which is that we actually when PARP inhibitors are named, they have similar endings. So these are the current PARP inhibitors, so olaparib, rucaparib, niraparib, talazoparib, and you can see that all these kind of end the same way. Veliparib is the only kind of mainstream PARP inhibitor, if you will, that does not have an FDA approval at this time. None of these drugs have been compared head-to-head, so we don't know if one is better than the other, and we can't know that without doing them head-to-head. So the decision on which drug to give, some of them do have different indications. For instance, rucaparib and niraparib have not been approved in breast cancer, so they would not be given in breast cancer at this point. But other than that, it's a little bit what physicians are used to. They have slightly different toxicity profiles. So talazoparib is also approved in breast cancer, as is olaparib. Talazoparib in combination with chemotherapy at this point is just in clinical trials. Immune therapy, there is a lot of interest in immune therapy, particularly for triple-negative breast cancer, but that is not specifically FDA approved at this time. All right, and then let's see. Another question. All right, let's see. The next question is a very interesting question about the combination of radiation with immune therapy and potentially immune therapy or PARP inhibitors for BRCA-related cancers. So the way to think about this a little bit to explain it better is, as I mentioned, the breast and ovarian cancers tend to be, if you will, immunologically cold. They don't have a natural, in general, they don't have a lot of immune response to them. There's always some exceptions, and triple-negative breast cancer is sometimes is immunologically hot at baseline, but mostly they're not. So if you're going to, you have to create then you have to get the T cells there somewhere. You have to create this immune response. So some of the ways that you might do that are to give something like a PARP inhibitor to kill off some cells and generate some gunk for the T cells to look at. And another way is to give sort of a dose of radiation. And that has been sometimes called RADVAX, doing radiation almost to create a vaccine to develop this T cell response. So how to do these things best in combination: radiation and immune therapy, PARP inhibitors and immune therapy, the combination of all three are really interesting and, again, understudied. All right. Next question is about screening. We always get a lot of questions about how men should be, what kind of screening men should get. And for this, the answer is that there are specific things that we know men are at risk for, particularly for BRCA2 mutation carriers, and those include an increased risk of male breast cancer, where the baseline risk in the population is 0.1%, and that risk goes up to about 5 to 7%. So at the minimum, we do breast exams and make sure men know that they can get breast cancer, and in specific situations, we do get mammograms. Prostate cancer is definitely increased in BRCA2 carriers, so we do recommend prostate cancer screening with PSAs. That is something that, as many know, is kind of debatable out there in the general, in the overall community, but for BRCA mutation carriers, it's definitely recommended. And then there is melanoma, particularly for BRCA2. And so for both women and men, we discuss dermatology exams. And as mentioned, the risk of pancreatic cancer is both for women and men. And we talk about the different screening modalities, as I mentioned before. Another question is when to test your children. So for women, we do, if there's a BRCA mutation in the family, we generally do recommend testing starting at the age of 25 for women, and that's because at 25 we start breast MRI screening. Now, whether or not to get tested before that, it has been the recommendation of multiple different guidelines that children under the age of 18 do not have genetic testing because there are no known increased childhood cancers in BRCA1 and 2 mutation carriers, and therefore that's why we talk about it as an adult. After the age of 18, we'll talk to anybody about this, but having information that you have a BRCA mutation, but then not starting screening until 25 can be its own problem. So that's very dependent on the individual. For men, we don't really do much until 35 to 40, but another reason to get tested earlier than that is because if you have a gene mutation, there is the opportunity to do something called preimplantation genetic diagnostics. And that's when people go through in vitro fertilization, screen the embryos, and then only reimplant the embryos that do not have the gene mutation. And so this is obviously not required, but it is an option that some people are interested in, and therefore that's another reason to consider testing. When considering testing, we also do generally talk about the Genetic Information Non-Discrimination Act. GINA, as it's known, does prohibit the use of genetic information to be used against you for health insurance, for jobs, things like that. But there are no provisions regarding disability insurance, long-term care insurance, or life insurance. And so those are, this is an area that's kind of active interest and study, but it is something that we cover in the process of pre-test counseling. So that's another consideration. Let's see, I've got 3 more minutes left. I don't want to hold people up too long. And in terms of what screening we recommend, again, for young women, starting at 25, we recommend an MRI. At 30, we add on a mammogram, and we talk about ovarian cancer screening really starting around 35 or so. Ovarian cancer screening really doesn't work very well, so then we talk about having the ovaries out, as we mentioned. The discussion about mastectomy is very individualized, and there's a lot of other things that we discuss, hormone replacement therapy, how to screen around pregnancies. There's a lot of different issues that we face. All right. Well, at this point, I think I've covered. A few more questions. So a really good question was about that whether or not individuals should get tested for both BRCA1. If there's a known BRCA mutation in the family, what should the individuals get tested for? One of the questions we always ask is if people are of Ashkenazi Jewish descent, even if there's a known specific mutation in the family, we generally test for all 3. The most important thing to do in these situations is to test for the known family mutation. These days, testing has gotten really cheap, so a lot of people are offered testing more broadly, and that's really kind of an individual decision. We still generally talk about just testing for the known mutation in the family. In terms of specific testing companies, another great question. This actually is dependent on a few different things. It depends on the individual's insurance. It depends on the family history because of the genes we would want to order. These days, we don't really just do BRCA1 and 2 testing. We order panels of genes. And if there are specific things in the family, we want to, if you will, cover them. So, for instance, if we're worried about colon cancer syndromes in addition to BRCA1 and 2, we would cover those. So there are a number of very reputable companies, though, and some of them have very fixed panels, like Myriad Genetics has a set panel with a certain number of genes on it. And other companies, there's a lot more flexibility, and you can add on different genes that you want. So companies like Invitae, Ambry, GeneDx, Myriad. There's also, of course, Color, the University of Washington, Quest, LabCorp. You're getting the idea. 23andMe does not do full BRCA1 and 2 testing. Although they are authorized by the FDA, all of their material specifically says that if you find a mutation in that way, you should get it clinically confirmed before you do anything. So, that's just that specific caveat. All right, so with that, I'm going to thank you for your attention. And Sam, I don't know if you had any last comments or if we're all done.
Basically, just a reminder that if anybody wants to share the webinar or listen to it again, it will be up on our website in a couple days at bastard.org/webinar. And thank you, everyone, for listening.
Thank you very much. Bye-bye.